that's okay. Again, thanks for having me. Can everybody hear me first off?
Yes.
Okay, good. So again, this was set up thanks to St. Peter's Hospital and your community, so I appreciate you having me here to talk again. Dr. Buxbaum. I am with Advanced Orthopedics and Sports Medicine Institute. We have offices in Monroe and Freehold. And I specialize in the treatment of hip and knee arthritis. I'm specially trained in both hip and knee replacement, including the initial surgery as well as revision surgeries if that needs to be done. I've been here for about 3 years now, and of course a lot has changed in the last 3 years. One was, of course, the big thing was COVID, which changed how all of us live. But for me personally, this is what my family looked like when I started practice, and this is what it looks like now. So things are moving along. Specifically, to get on the topic we're here to talk about really is hip and knee. What's happening to your joints as we age? What is arthritis? What are some treatments that we can do? And we'll work our way through that. So to start off with, what can cause wear and tear, wearing down the knees? Arthritis is the most common, but there are other things like injuries that can result in that. Different conditions also, if you have rheumatoid arthritis or psoriasis or things like that, that can also cause wearing down of the joints. As far as osteoarthritis, which is your simple wear and tear, the common picture that we present is that normally your knee should have good, healthy, smooth cartilage, or your hip as well, and that's represented by this kind of smooth blue area. And then on the other side, you can see how the bone has these what we call bone spurs or osteophytes. The cartilage is no longer smooth and it's breaking down, and that's the basic picture of what happens in arthritis. As far as what you may feel when this is happening, stiffness, pain, loss of mobility, limping, various other symptoms can present themselves that can clue you in that maybe your joints are starting to wear down or getting inflamed and injured. Specifically for knee arthritis, one of the things we talk about is pain at the joint line, which is pictured by these circles over here. You may also feel like a crunching or crackling feeling within the joint. You may feel like the knee's getting stiff, especially worse in the morning or after you sit for a long period of time. The appearance of your knee may also change so that it starts to take on this kind of more boxy appearance. So this knee on this side, on the left of your screen, is an arthritic knee, while the other one is more normal, and you can kind of see how the knee just looks bigger. And again, you may notice that the knee is getting stiff, you may be losing some motion, or you may start limping. You may not even realize you're limping. It may be a friend or a spouse or someone else who asks you, why are you limping? And sometimes that can be the first sign that something like this is going on. With hip arthritis, it's similar ideas. The pain is a little bit different, of course. Mostly it's localized in the groin, which is where the hip joint is. Some people will get pain elsewhere, like in the back of the hip or the side, but the most common place we see it with hip arthritis is in the groin. A lot of people will say they have difficulty putting on their shoes because their legs don't turn the same way that they normally do. So that's a common presentation I'll hear. And then also similar to the knee, stiffness, especially worse in the morning or after sitting for a long time. And the other thing people will sometimes tell me is they feel like their leg lengths are no longer the same, that they're leaning to one side, that they're off balance. And that can happen because as the hip wears out, the leg actually will raise up more into the pelvis. So this is a picture showing how the hip, again on your left, this is the right hip in a person, is wearing out, and the leg is essentially raising up higher on the right side than the left, and it gives you the appearance that that leg has now become shorter. And some people will develop worsening limp or even instability. They'll become unstable while walking because of this. I get this question a lot when I see people for hip or knee pain. We take an x-ray, I examine you, I tell you this is what I think is going on. People ask, should I get an MRI? And the answer to that is usually not with arthritis. And the reason is this on the left is your normal knee x-ray, and we look at the joint space. As long as there is a good space between these two bones, your femur and your tibia, that is a sign that you have good, healthy cartilage left in the joint. As that space narrows out, and here you can see the bones are actually touching, which is what we commonly refer to as bone-on-bone arthritis, this is a pretty obvious thing we see on x-ray. And so an MRI in this kind of case wouldn't be necessary. Now this is an extreme or more severe presentation of arthritis, but even when it's more mild, you can still start to see some of these changes and differences with the joint space. You can also start to see bone spurs or the coloring of the bone changes. You can kind of see how this is a thicker white than it is on the normal side. So an MRI really isn't necessary. It's not going to add anything. And similarly for the hip. again, here you see this normal space between the ball and the socket. That's how the hip should look. And on this side, you can see that space is gone. It's hard to tell where the ball and the socket end. There's also some cysts that form within the bone and a bone spur out here. And again, so an MRI really isn't going to add anything here. So typically for arthritis, we don't recommend MRIs. Now that's when our MRI is useful, more for soft tissue injuries, if you have a meniscus tear or a labral tear, or if the x-rays are normal and you're still having pain that seems consistent with maybe arthritis, then an MRI might be useful. So it's not a never get one, but in most cases it's not needed. As far as early treatment, I'm going to take you from kind of the beginning, the most simple things that we can do, all the way through the surgeries that we offer. So the initial treatment for hip and knee arthritis are basically the same. The goal, of course, is to help decrease your pain, increase your function, get you back to your life. And there are many options for that. One thing we talk about is lifestyle modifications, basically meaning if you're doing something that's hurting your joint, changing how you do that. Walking with a cane or a walker may be one form of that. There are medications, injections, and other things like that that we'll go through. So the most simple thing, again, I talked about a little bit. You can use a cane or a walker. We'll get into that a little bit later as well. But simple exercise, keeping your joints healthy and strong, is a good way to prevent this from getting worse. Also, a healthy diet, proper nutrition can help maintain your joint health and your overall activity. And then weight loss. Your joints in your lower legs, your hip, your knee, even your ankle, feel about 3 to 5 times your body weight. So the force across those joints can increase as you get heavier. So maintaining a healthy weight is also important to help keep pain and keep healthy joints. As far as medications, our first line medication is typically anti-inflammatories, what we consider these NSAIDs, non-steroidal anti-inflammatories. And those are usually your Advil, your Motrin, your Aleve, Celebrex, Meloxicam for people who have had prescription versions of these. They do have some side effects. We do have to be careful with other medications that you may be taking. If you have any kidney disease or stomach irritation history, those are things to be careful with. But otherwise, that's usually the first line treatment because they directly impact the inflammation within your joints to help with the pain. Other medications you can take, such as Tylenol or acetaminophen, and then narcotics we typically try to avoid as they have other side effects such as constipation, mental effect. They do have some addictive potential. So typically if we are going to do narcotics, the one we recommend is tramadol, which is a lower strength narcotic, has less addictive potential and less side effects. That is, of course, only a prescription medication. There are also some topical medications that are available. One of the main ones we use these days is this Voltaren gel. It is a topical anti-inflammatory. For the knee, it is a good option because the knee is a fairly superficial joint, so the medication can actually get down there. For the hip, which is a much deeper joint, it doesn't work as well, but it is worth trying sometimes. And similarly, icing the joint or applying a heating pad to the joint are also options. As far as injections, there are a number of different injections out there. The two main ones that we promote are cortisone or a corticosteroid, as well as the gel shots. So the steroid injection, again, the idea is it's combined with a local numbing medicine like a lidocaine to give you some initial relief, and then the steroid takes 2 or 3 days to kick in, and it is meant to calm down the inflammation. It does not treat the actual arthritis, it doesn't prevent it from getting worse, but it's to treat just the pain and inflammation. We typically recommend spreading these out by at least 3 months. If it's done too frequently, the steroid can actually weaken the cartilage, the bone, the tissues within the knee or hip. For the gel shots, which the medical term is the viscosupplementation, there are a number of different brands out there, Synvisc, Reflexa, Gel 1, among many others. The idea with these injections is that the compound that makes them is called hyaluronic acid, which is a naturally occurring substance that's part of your typical synovial fluid and cartilage. And we inject this medicine into the knee to try and help smooth out the cartilage, fill in the cracks. Typically, the worse the arthritis gets, if you reach that bone-on-bone level, it doesn't seem to work as well because it doesn't have that cartilage that it's meant to bind to. This is also only approved for the use in the knees currently. I know some doctors will use it in the hip or other joints, but technically based on FDA approval, it is only for the knee. And this medication has to be spread out by at least 6 months. There are different options also for how this medication can be given. It can be done in either a single injection or a multi-shot series of injections where you get one injection every week for 3 to 5 weeks. That is how the medicine was initially developed, thinking to spread it out and give you more of a time span of the insertion of the medication. But nowadays, the single shot does seem to work fairly equally as well. But everybody responds differently to different brands or different ways that this is injected. So it's important to have that discussion with your doctor about how it may be best utilized for you. Other types of injections that we commonly are promoted, or some people do, which I don't have up here, are PRP or stem cells. PRP is we take blood from you, we spin it down, we try to collect the good healing factors, and we inject it back in. For arthritis, it's sometimes can help with the pain and inflammation, but again, it doesn't heal the actual arthritis. Stem cells have less research behind it. The idea is we take these cells that can develop into anything, inject it into your joint, and it may help develop into new cartilage. That hasn't been found to actually happen, but you will see some people out there promoting it. I personally do not do that injection because I don't think scientifically it makes sense or that it works. Going into the support devices, I talked a little bit about canes and walkers. The idea is to help take pressure off the joints and use your upper body to help support that. But there are also braces that can be offered, specifically, especially for the knee. There are braces that are called unloader braces. The idea being if you are wearing out more on one side of the knee than the other, such as the inside of the knee, this brace may actually be able to push your leg just a little bit to get your body weight more on the other side of the knee that is healthier, and that can help take some pain away. Other braces, such as just simple knee sleeves, can also be beneficial. The idea of compression on the joint sometimes makes the joint feel better and gives you a little extra sense of security. With the hip, there are braces out there as well, but less so because, again, the hip is a deeper joint and it's more difficult to get a brace that will give it that kind of support. Going away from now the non-surgical options, we start to talk about knee and hip replacement. And again, a common question I get is, how do I know if it's time? When do I know I should get my joint replaced? And I will tell people that it's not really the right question. It's not that you necessarily need it, but should you get it? Again, knee and hip replacement are elective surgery still. Yes, in some people who have severely debilitated function and pain, it is the right answer, but it doesn't mean you have to do it. And there are some patients who are at significantly elevated risk that we do not actually recommend doing it despite the condition of the joint. So should I get a knee replacement? One of the good knee or hip replacement, one of the reasons to do it is if you've tried all the treatments we've mentioned before and they're not working for you. The injections no longer help with your pain. Physical therapy or exercise hasn't given you any relief or has actually made your pain worse. This is the final step that will ultimately treat the arthritis that you have and can get rid of your pain and get you back to function. Other reasons, of course, can be if you're losing your function, you haven't tried any of your other treatments yet, but you're at the point where you're not able to walk because the arthritis is so severe, it may make sense to just proceed directly to surgery and not waste your time trying things that are unlikely to be successful. If you have a major deformity of your leg, if your knee is angling one way or your hip is significantly short because the joint is so worn out, those are other good reasons to get this type of surgery because we can address those complications with surgery. I can straighten your knee with a knee replacement, I can get your leg length back to where it's supposed to be with a hip replacement. And this is something that I mentioned with the deformity of the knee. You can see you're either bow-legged or knock-kneed, where the knee is no longer straight in line with the leg as it's supposed to be. And this shows how those bones kind of change along with that. As far as the surgery goes, hip and knee replacement are among the most successful surgeries we offer in all of medicine. I commonly tell my patients that hip replacement especially is probably the best surgery that we have to offer in orthopedics. And the idea is not that we're taking out your entire joint, but we're replacing or resurfacing the damaged bone and cartilage with metal and plastic to get you a new, smooth surface that functions well. The basic idea of a hip replacement is we remove the ball from the top of the femur and we clean out the inside of the socket. And this allows for us to put our new metal implants in their place and gets rid of the arthritic bone and the damaged cartilage. And so on the socket side, we put in a new metal socket that typically has a plastic liner that sits inside. Sometimes that can be metal. And on the femoral side, we put in what's called a metal stem that sits inside the bone, and your bone will hold this in place with a new ball that sits on top of that, and then the ball goes into the socket, and that gives you your new joint. Typically, when this is done, the pain from the arthritis is gone almost immediately. Of course, there's surgical pain, muscle swelling, muscle soreness, bruising, things like that are normal. but the pain that's deep within the joint is typically gone, and we restore your motion with this type of replacement. As far as knee replacement surgery, it is a similar idea. Again, this is the bottom of the knee or the tibia. We remove the top portion of bone and put in what's called a metal tibial tray that sits on top. And then on the femoral side, we cut around the edge of the bone to make this new rounded look that a rounded femoral component sits onto. Typically, these components are glued into place with what we call bone cement, but there are some cases where this can actually be what we call press fit into your bone, and your bone heals to it. With hip replacements, we typically do this press fit technique all the time. The implants are made to allow for bone to heal into them so they become a biologic fixation and part of you and should hold up for the rest of your life. With the glue technique, it should typically last at least 20 to 30 years, but it can at some point come loose. And this is then generally what the knee replacement looks like after, with the tibial tray and the metal femur and a plastic part in the middle. We will sometimes also resurface the back of the kneecap if that's worn down with a plastic disc. I don't have a picture of that here. For knee replacements, there's also different options. There's the full knee replacement, which is what I just showed you, but there's also partial knee replacements, where if your knee is only worn down in one section, such as the inside of the knee or the outside of the knee, we can just replace that portion of the knee joint and leave you the rest of your normal knee. The benefits of this type of procedure is that you keep the majority of your knee so it feels more natural, feels more like a normal functioning knee. The recovery is typically easier because it's a smaller surgery. There's less pain, quicker return to function. The downside of the partial knee is that it could eventually wear out in the other portions of the knee, and it may then need to be converted to a full knee replacement, which means potentially another surgery down the road. Partial knee replacements, typically we tell people should last at least 10 to 15 years. Full knee replacements we say should last at least 20 to 30 years. So there's another reason that people will sometimes lean one way or the other. If they prefer to have lower risk of needing to have this redone, going right to a full knee replacement can be the correct option. As far as where we've come, we've been doing knee and hip replacements for over 50 years, if not longer. But things are always being updated and changing. One of the big things with hip replacement is how we get down to the hip. Classically, we used to go through what's called a posterior approach, or through the backside of the hip. The newer technique that a lot of surgeons are taking, which is the way I do my hip replacements, is through the front, which is called the direct anterior approach. The benefits of this are, when we went through the back, we had to cut through some muscle and also take down some of the main stabilizers of the hip. When we go through the front, we keep all of that intact in the back, and your body actually has a natural plane that we can use between muscles, so we don't cut any muscle to get into your hip joint. The reason I mentioned those stabilizers of the hip is because if you know anybody that's ever had a hip replacement, we usually tell them when it's been done through the back at least, we tell them there are certain motions not to do. Don't sit on a low seat, don't cross your legs. And the reason for that is because this ball and socket are not attached. And if you find the right position, you can actually pop it out and dislocate it. So that's one of the big complications with the posterior hip replacement. When we go through the front and we leave all that intact, the risk of dislocating is significantly less. Now that being said, posterior hip replacements still work very well. The dislocation rate, based on the research, is somewhere around 2 to 3% posterior. So the majority of patients, this is not an issue. But through the front, that dislocation rate is less than 1%. So it is a significant benefit. The other thing, because we don't cut any muscle, the pain and recovery initially is usually a little bit easier than going through the back. So there are a lot of benefits and reasons why I like to do the anterior approach. And I think it's becoming more and more popular, and more surgeons are doing it because of the benefits. For knee replacement, we used to make these big incisions and cut into the quadriceps tendon, which is what inserts into the kneecap. And we were finding that patients would have some weakness, difficulty getting going in the early going. So now we've developed techniques where we don't cut the quadriceps tendon, we cut it along the side. It's more minimally invasive, the incisions are typically smaller, and also you maintain more strength immediately after the surgery. It makes the early recovery easier, you get back to walking sooner, and so these are other techniques that have helped make these surgeries better. And one of the other big things that's coming in now within the last 5 to 10 years is robotic knee replacement, or robotic hip replacement also. And the idea for this is to make our joint replacement surgeries as accurate as possible. Classically, we use cutting jigs and guides to help make sure the measurements are correct, we're cutting in the right place, we're doing the correct surgery, and that does work very well. Again, we've done these surgeries for a long time, and we've had very good results. But using technology like this to help make sure it's as accurate as possible, I can see on a computer screen that I'm cutting the bone where we cut it to within a ½ millimeter where it's supposed to be at the correct angle. So this is a good tool to make sure things are as accurate as possible. Is it necessary to use this to have a good outcome? Of course not. And there are reasons even not to do this, because in order to use the robotics, typically we need to put some type of pin or tracking device into the leg temporarily, and that could require additional incisions. And if you have lymphedema, for instance, we don't like to make additional incisions on the leg because it increases the risk of infection. But overall, this is a good tool in becoming more and more popular to do joint replacements with. Moving on, one of the next common questions I get is, am I healthy enough for joint replacement surgery? Can I go through this? A lot of people come to me, am I too old? Do I have too much heart disease? Is my diabetes limit me? And there are varying factors why. We take the whole patient into the picture when we make these kinds of decisions. I tell everybody there's no hard age cutoff. As you can see, I put up here, success in joint replacement can happen even into the 90s, but it's the overall health and function that we take into account. That being said, there are some hard cutoffs that prevent us from doing joint replacement, and the reason for that is based on the research. We know that the risk of complications, risk of failure gets significantly higher past these points. So body mass index is one of these main factors that we look at. That is a combination of your height and weight. Most typical healthy people are considered to have a BMI between 20 and 30. Overweight is between 30 and 40, and obesity is above that. Once you're over 40, your risk of complications, infections, the implants coming loose, other problems goes significantly higher, and so we recommend not doing joint replacement on anybody with a BMI over 40. Additionally, if you're a diabetic and you get your hemoglobin A1C measured, we want that number to be below 8. The reason being, if it's below 8, that's showing that your blood sugar is not controlled well enough to promote your healing, to prevent infection, and give you a good successful outcome. The risks are too high to proceed with surgery at that time. There are other things we look at, such as kidney disease, heart disease, other reasons, and I ask your medical doctor, your cardiologist, other doctors to come in and tell us if they feel that this is a safe thing to proceed with for each individual patient. And as it says there, I do try and speak to those doctors and help coordinate this. What if you've already had a joint replacement? Again, we do a lot of joint replacements. It's becoming more and more popular in the community. We do about 1 million knee replacements a year in this country, and somewhere between 500,000 to 1 million hip replacements a year. If the knee or hip is functioning well, we typically recommend that you get your joint checked every few years just to make sure there's no signs of wearing out of the joint. Again, as I said before, typically full knee replacement should last about 20 to 30 years, but they can wear out at some point, and it's better to catch this early rather than late. And so, as I put up there, joint replacements, if they were older, they typically don't last that 20 to 30 years. They're a little bit shorter lifespan because the implants that we were using wasn't as good. Nowadays, they hold up longer. How will you know if the joint needs to be redone? Is it wearing out? Is it giving you any problems? And there's a lot of different signs that we look for. The main one is pain. If you've had a knee replacement, it was working well for 5, 10 years, and now all of a sudden you're starting to have pain, it's worth looking at. It may need to be redone. With a hip replacement, you were doing great for 10 years, and now all of a sudden the hip dislocated. What happened? Is something wrong? Does something need to be redone? It's worth checking. And so there are a lot of different signs we look for. Stiffness, loss of motion, pain, changes in the angle of your knee or your hip could be occurring. And it's worth getting that checked because those are reasons that it may need to be redone. These are just some pictures of why a hip replacement might fail, why it might need to be redone. So the picture up here shows what a dislocation looks like, that the ball is no longer in the socket. The picture all the way here on the right shows that the socket has moved. It's no longer where it's supposed to be and the hip is coming out. In this image, this shows that the ball is no longer centered in the socket, which could be a sign that the plastic is wearing out, as you see here. And so this is something that if we see early enough on x-ray, we can do a surgery where we go in and just change that plastic part and give you a new one, like an oil change for your car, and avoid a major surgery to have to take out the metal parts and redo it. And this is exactly why we recommend checking this every 2 or 3 years. And this is an image, this is pretty rare, but this shows that the metal could break with enough stress across it or an injury. And then these are similarly knee replacements that have failed. Again, this shows that the angle of the knee has changed. The tibial component, which should go straight up and down or be perpendicular to the tibia, has shifted. Here you can see that, again, this isn't an even space across, so the plastic has worn out Similarly here, which is the same idea as I just mentioned for the hip. If this is caught early enough, we can take that plastic part out and put it in a new plastic part and leave all the metal parts in place. It's an easier surgery to fix at that point than if the metal starts to wear out. Here, this is again a sign that the knee has shifted out of place and is dislocated. And this one also is showing that the kneecap has fractured and is overgrown with bone here. Again, how likely is this to happen? After I showed you all those scary images, why would you ever get your knee or hip replacement done, knowing that this could happen? Well, it's pretty rare. It's estimated that lifetime about 12% of knee replacements will require to be revised at some point. So that means most people who get their joint replaced, well over 85%, never need to have it redone. And it's even less so with hip replacements that it needs to be redone. Again, as I mentioned before, it's recommended routine follow-up to make sure nothing's going wrong, that everything's staying intact, nothing's wearing out. And again, most painful joint replacements, if you have a joint replacement and it gets painful, it doesn't mean it needs to be redone. Most of them can be treated with conservative options like medication or physical therapy, sometimes bracing. Sometimes if you have pain in your joint, it may not even be from your joint, it could be from somewhere else like your back. So it's worth coming in, get it checked, and get it worked up and see what we can offer. In summary, again, arthritis is very common in the community, especially in the aging population. There are many different conservative options that we can offer, from medications, injections, exercise, before we need to go to knee or hip replacement. But if you do need a joint replacement, it is among the most successful surgeries we have to offer, and patient satisfaction is very high. And thank you very much for coming. I appreciate, again, you welcoming me here and taking the time. And again, these are our offices. We have an office in Freehold and one in Monroe. The one in Monroe, which is closer for you, is located on Cranberry Half Acre Road and Applegarth Road, right behind the Walgreens.